6 foot.
Speak louder, Matthew.
Me, golf swing, and
Ooh.
giving a talk on cardiology with cookies and we're talking about arrhythmias today?
I think so, yeah.
Yeah.
All right.
All right. Thank you.
There you
go.
Take it away, Nate.
No stress.
Make sure everyone help yourself to cookies too.
You get a cookie for that.
Yeah. Make sure the fellow gets a cookie. So I thought that I think a couple people have brought up that just to talk about some common post-op arrhythmia. So I thought that was a pretty good topic. So and I think I chose the two that we'll talk about as I think the most common that we see here is SVT and JET, right? Those are the two that we see all the time in the post-operative period. And I think that the treatment and kind of how you think about them is different, and there's I think that's important. So that's why I wanted to talk about, because there's like different pathways, and they are different, obviously different arrhythmias when they originate in different places, and I think that's important to know into how we treat them. So the two types, there's two overall. There's actually two different types of atrial tachycardias or arrhythmias, and one big broad group is called a reentrant group, and the other one is called something called an automatic tachycardia. And so, if you can imagine, the reentrance ones are the ones that just sort of start usually in the atrium, and then go down through the AV node and then into the ventricle and then come back up. So they make just like this big pathway. That's why they call it reentrant. And an example of that is SVT. So SVT is a reentrant tachycardia. And then another type of reentrant tachycardia is like atrial, is like AFib or atrial flutter. That's reentrant because the kind of abnormal pathway starts in the atrium and just kind of circles around in the atrium. And so those are examples of reentrant tachycardias. The other type is called automatic tachycardias, and that's what JET is an example of. And so JET is an example of one. There's other more rare ones that we don't see too much, but things like multifocal atrial tachycardia, ectopic atrial tachycardia. Those are very kind of rare ones, but the JET is the most common form of automatic tachycardia. And those just usually the JET starts down, if you didn't know this, it starts actually right near the AV node, and then it just sort of goes right down into the ventricle, and it just starts there and just keeps firing. So there's some abnormal place near the AV node that just keeps firing automatically, and it just keeps firing, and that's what makes the heart rate go faster and faster. But it doesn't go back up into the atrium like the other, so that's why it's not a reentrant tachycardia. And same with those other more rare ones, they start up in the atrium and then just kind of fire off down into the conduction system. A quick review if you haven't thought about it, because I've probably been throwing out a couple of terms if you haven't thought about the conduction system in a while. Just a review is, so in all of us, the heartbeat starts usually in the right atrium in most patients, up in what's called the sinoatrial node or the SA node. That's kind of like the body's pacemaker, and that just sort of fires every, as often as you need to have your heart rate. And that's the body based on different hormones and other nerves can kind of control how fast or how slow your heart rate is. So if you have a big vagal response, if you suction somebody, that's going to cause your heart rate to go down. Or if you're very excited and release a lot of adrenaline, then that's going to cause your heart rate to go up. So you start in the right atrium in the SA node, and then the electrical wires head down into what's called the AV node, which is right between the atrium and the ventricles. And that's sort of and then it goes on and goes down into the ventricle and then conducts, and that causes the ventricle to pump and then squeeze the blood out of the heart. So again, the two types are, again, the automatic, which is JET, and then a reentrant, which is SVT. And some clues to kind of how you approach them is that reentrant tachycardia is all of those. Atrial flutter, atrial fib for the most part, SVT, those are all reentrant ones. Those will start and stop very abruptly. So you'll just be noticing that your patient will have a heart rate of, let's say, 100, and then you turn around and all of a sudden they're at 200. And if you look back on the monitor, they are just sort of, that's the abrupt change. And that's a very good clue that your patient has some sort of reentrant tachycardia, so flutter or SVT. That'd be a really good guess. Whereas the automatic tachycardias like JET and the other ones we talked about, but again, JET's going to be the most common we'll see, those are going to, we call ramp up more slowly. So you'll just sort of notice that the patient will be 120, then 130, then 140, then 150, then now they're 180, now they're 200. So it's a very slow ramp up. And that's a very good clue that they're in JET versus SVT. Because sometimes we have a patient like a baby come back from the OR and they're 200 and we're trying to figure out is it JET or SVT. So that's a nice clue to say, did it just happen suddenly and that's SVT, or did it gradually warm up? Also the reentrant tachycardias, again SVT, flutter, those will be a very constant heart rate. So you'll just see they won't change at all. They'll be 200 or 190 or 180, whatever it is, and it will not budge within a few points. And it'll just be going on, and whatever the patient's doing, it will not change. Whereas the automatic tachycardias, again, something like JET, is going to have a little more variability. So they'll be fast. They'll be faster than we all want them to be. They'll be 160, 180, but they'll have some variability based on what the patient is doing, whether they're agitated or sedated. They'll have some variability. So that's a good clue as well. So those are some big differences in how we treat them, how we look at them initially, and that affects a little bit on how you treat them as well. So I think that you probably have all seen. I think that some easy things to look at when a patient's having an arrhythmia that we think is not just sinus tachycardia is to certainly HISTA-1. First thing is to get an EKG, and it's nice that most of the patients post-operatively, most have atrial wires, and what we do with that. So we can use the atrial wires, and what we do is we hook that up to one of the leads of an EKG. And what that helps us out a lot is that sometimes when the heart rate is going so fast, when it's 180 or 200, and you look at a standard EKG, what we're really trying to do is we're trying to see if there's where the P waves are, right? Because if it's just sinus tachycardia, you'll see the normal P waves before the QRS. But sometimes it's going so fast, or they have all these other abnormalities, it's really hard to see. So we use the atrial electrogram. We hook up an A wire to one of the leads, and that gives us a really good clue of where is the P wave heading. So so that can tell. So if it's just sinus tach, we'll see that the P wave is right before the QRS normally. If it's atrial flutter, we'll see the P waves beating really like multiple times for every QRS, and so that we know it's flutter. For JET and SVT, it's a little bit more confusing because they both are usually you're not gonna have true P waves. So sometimes in SVT they'll be either buried in the QRS or afterwards, and then you see the same thing with JET too. So I would say that an EKG is good for ruling out that it's not sinus tach or something else when you're trying to decide, but it's going to be less helpful to tell you if it's really JET or SVT. So the other things that we can use are things like adenosine can be helpful both for treating it and for diagnosing both of these tachycardias. So what adenosine does is it causes a momentary, few second block at the AV node. So normally the conduction system comes down from that SA node, the atrium goes through the AV node. The AV node is kind of like the gatekeeper of the electrical activity of the heart. It kind of makes sure, sort of gatekeeps how much electrical activity is going down into the ventricle. So what it does, the adenosine, all it does is it blocks the activity through the AV node, and it, as you all have seen, it blocks it for a couple of seconds, and then it comes out. It's a very short-acting drug, and it can be very helpful both for diagnosis and treatment of a lot of arrhythmias. So sometimes we'll give it, and sometimes we're hoping it might work, but sometimes it gives us a good clue of what's going on. So the reason it works very frequently, and it's the treatment, as you know, and it's in the PALS algorithm for SVT, is because, remember I talked about SVT is that reentrant. So you have electrical activity that's starting in the atrium, going down through the AV node, and then kind of somehow there's an abnormal pathway that's kind of circling back up. So you can imagine if you just block the AV node conduction, you'll kind of block that reentrant pathway, and you'll kind of reset the heart, and then the heart won't go back to beating normally like it should. So that's why adenosine works in SVT, or we hope it works. In an automatic tachycardia like JET, remember it's starting somewhere near the AV node, but it's just sort of kind of firing down into the ventricle. So even if you block the AV node, you're not blocking. That's why adenosine never works for JET. It's not the treatment for JET, and it will never work. So that's why sometimes we'll try it, but adenosine is really not the treatment for jet. But it can be helpful if you're not sure what you're dealing with in terms of arrhythmia. Sometimes we'll give adenosine, for example, and you don't know what's going on, but you kind of see that pause, but all you do is you see a lot of P waves on the monitor, and you say, oh, well, now we know it's flutter because there's like a bunch of P waves there. So it can be helpful too. There's never any downside to giving adenosine, especially if you know in an ICU and you have full monitoring, and there's hardly ever any times where it's. In fact, I can't think of any times where it's not the right thing to do. It just might not help you. That's a big thing, and it might but you know that if you really know your patient has jet, adenosine is not the treatment because of what we just talked about. The other things that so we'll go back to for SVT. So the treatments are, if you kind of remember the PALS algorithm, you have to decide as the patient sort of how are they. Once you establish that they have SVT, you say are they compromised or not. So many times here post-operatively it ends up compromising them a lot, so they get hypotensive and don't look very good. So then what are your options? Well, so you have to do something rather quickly. And so it's either adenosine or the other really fast, other quick thing we can always do is hook up the pacer and rapid atrial pace them. So that's the other big difference. And again, this is just kind of going back to thinking about what those big boxes of the tachycardias are. So rapid atrial pacing where we give short bursts, maybe like 2 or 3 times what the normal heart rate is. So like at a rate of about 300 or 400 beats per minute, just for a couple of seconds through the pacing box, right into the atrium. That can be very, very effective at terminating all reentry tachycardias. That's why it works for SVT. It works for atrial flutter. It can work for atrial fibrillation too, because of all those reentries. Because you're delivering kind of a lot of beats, you're kind of resetting the heartbeat, resetting the kind of the clock in there, and that's why it works better. But rapid atrial pacing will not work for automatic tachycardia, so it's not the treatment for jet, and that's why it doesn't work. Because you can give a lot of rapid paces to the atrium, but again, the problem is that rhythm is starting to get down in the AV node, a very abnormal place, and that's why it's firing there. So you can give a lot of paces there, and that's not going to do anything. So sometimes, again, once you start to figure out which one is which, but that's kind of understanding why we choose certain therapies and certain other ones we don't choose. As I was thinking about it, it's good to kind of think about too what your patient has, and if you can give you again a clue of which arrhythmia they might be having as you're trying to understand too. So I think SVT can happen in probably almost any patient, especially ones that we take care of. I mean, any post-operative patient. I mean, it happens when anytime they're doing any manipulation of the heart or especially the atrium, and that really is almost all surgeries we take care of. So anytime there's any cutting into the atrium, that can be a risk factor of SVT. Of course, we've seen babies that have SVT even before they have any surgery, and then you can have that as well. So just being sick, being stressed as the body, being a newborn, all those things can put your risk for SVT. The other thing that's important to always remember is that lines can do it too. So lines can kind of tickle the atrium and again cause an automatic kind of firing, and again that just sort of calls it reentry tachycardia. And so sometimes if a UVC is really deep, or an IJ is really deep, or a PICC line is really deep and kind of flopping around the atrium, that can cause SVT too. So you can do a lot of treatment. You can do adenosine and cardiovert them and do all these things, but really the best thing to do is you could just get that line, just pull back that line a little bit. So, so I think SVT you could think of as almost any patient, especially I think the younger babies, like the infants, are much more high risk. But any surgeries, any conditions they can have SVT. In terms of jet, I think there's a couple really, and jet is all as opposed to SVT, where SVTs can be seen both pre and post-operatively. Jet is is really just a post-operative the first day or two of surgery, and then so you don't see it pre-operatively, and you don't see it 3 weeks out. You see it just that first night, and then for the first next day or so, and then it goes away. And it's really most common I think of it in any patients that have a lot of work on the AV valves or on a VSD closure. So things like VSD closures, TETs, AV canals, And then you also see them often sometimes in Fontans and heavy Fontans too. I think those are the TETs and VSDs and AV canals are kind of the most, if I would put any of the ones in your back of your mind, those are the most common ones that are going to have, you can have a higher risk of jet. We don't know actually what causes jet. It's thought to be, sometimes people think that it's because when the surgeons are doing the surgery that they maybe damage or put some strain on the tissue near the AV node, and that causes some inflammation, and maybe that's why there's an abnormal heart rhythm from there. But what we do know is that it's temporary. So we have to do, the whole goal is you're trying to just temporize things and get the patient out of that first day or two, and then the rhythm will eventually get better. So other things that we use for jet, so we talked about adenosine is not helpful. Rapid atrial pacing is not helpful because it's an automatic tachycardia. I'm sure you guys have all seen, we do things like correct the electrolytes, which are very important in both rhythms, right? So making sure the magnesium, the calcium, potassium are all normal. Especially magnesium, that seems to be one that really has a big impact on how the conduction system through the heart goes. That's a really important one. If it hasn't been checked, or if it was checked a couple hours ago, it's worth checking it. Sometimes I'll just give a dose if it hasn't, as long as it's not 3 or 4 in the last hit. I think sometimes that can really be helpful. So optimizing electrolytes is a big thing for both kinds of rhythms. Other things for jet. So jet is often made worse by things that make the heart rate go faster, and that's things like fever. So, or that's just anything that's making the adrenaline or all the kind of the hormones in the body kind of go up. So if they have a fever, you want to try to control that. Sometimes we'll actually cool them down really slow to try to, again, just trying to bring their heart rate down. And that can be either passively cooling or actually putting them on a cooling blanket. The other thing that you can do for jet is to try to, what we try to do is to try to limit, again, limit any drugs that we're giving that are going to be making the heart rate faster. So, which is unfortunately a lot of the things we use. So dopamine, epinephrine, those are all going to make the heart rate go faster. So we sometimes will tailor the drips that we're on to use other agents that won't make the heart rate faster. Sometimes that's why we'll, in a patient with jet, we'll say, well, let's start some vasopressin, or let's start some norepi. Those are both drugs that don't raise the heart rate, they just help with blood pressure only. So try to minimize the things that cause the heart rate. But that can be anything, so trying to keep the patient very well sedated, sometimes even paralyzing, and try to keep the patient very calm, get their heart rate lower. That'll all be effective. Again, you're not trying to get them out of jet. SVT, you're trying to get them back into normal rhythm. Jet, it's sometimes very hard to get them out of jet, truly. But you're just trying, the real problem with jet is that it's too fast. It's just too fast of a heart rate. 180, 190 is just too fast for that particular heart. So by getting them down, sometimes if you just get them down 130, 140, 150, they'll have a much better blood pressure. So I think cooling, minimizing dopamine, epinephrine as much as you can, sedating them, all those things are going to bring their heart rate down. You've probably seen sometimes we do end up pacing a patient with jet. And again, we're not doing that rapid atrial pacing like we are for SVT, but one other big problem why jet can cause a lot of hypotension is that, again, you're not having we call this sort of the normal AV conduction. So you're not having that, people talk about the normal atrial kick. So you're not having the normal atrium contracting that ventricle. And that's a very normal thing that the heart is very used to, the atrium ventricle. So you're just having this atrium is kind of doing whatever it wants, and then this, remember that focus is kind of starting down here, and it's just sort of firing to the ventricle. So you're not having that normal pattern. This is sort of beating on its own, and this is beating on its own. So that's why they can get hypotensive. It's just not a very effective cardiac output. So if we can restore that normal way that the heart is beating, that can often help with blood pressure. So if you can get the heart rate down low enough, like say 120s, 130s in a jet rhythm, it still may be jet, we still may call it jet, but if we pace the atrium and just say we want it to pace a little bit faster than that rate, not 200, but say just 10 points higher, that sometimes can be very effective because that restores that normal pattern. So sometimes that's why we'll pace. Again, we're not rapid atrial pacing as we would in SVT, but we're just pacing. And that's why we'll do AAI pacing in some patients with jet. And then I think for both SVT and jet, getting back to it, then there's of course all the medications we can use, or some people I think they call them, there are a lot of the poisons we use too. But So most common one we use here is amiodarone, which is sort of a very sort of broad acting antiarrhythmic, and it works just on a lot of different receptors, and it's very potent. It works very well, but it also has a lot of negative side effects. It can cause problems with how the heart squeezes. There's long-term side effects with thyroid and pulmonary function, but it's very effective, so that's why we use it sometimes, especially when a patient's really sick. So amiodarone, I'd say, would be the sort of, if you try, in a patient with jet, if you try to cool them, limit all their drips that they're on, sedate them, correct all their electrolytes, you try to pace them if you can, and they're still unstable and they're really fast, then amiodarone would be the next thing we'll try. And it's usually effective, it just, we hate to use something that causes all these other side effects if we don't have to. And I'm sure you've all seen the usual thing is you have to give a loading dose of amio, and then there's a drip that follows after. And you can actually reload amio a couple of times and go up on the drip if you're not getting the effect you want. And then hopefully you can kind of start to wean that off as they get better. And again, jet is a very temporary thing, so just 1 to 2 days, and then they're usually out of it. And I think the final thing, if you've done all those things and they're just completely unstable, it doesn't happen very frequently, but every once in a while, a patient actually needs to go on ECMO because you just cannot support you cannot get control of their heart rhythm. And in jet post-op, and they're so unstable, and you think that that's the only reason. So if you just, again, the idea is you put them on ECMO, let things cool down, and then their rhythm will get better, and then they should be able to come off ECMO pretty easily too. So that's the kind of the final pathway there too. You can also treat SVT, like I said, some of the same ways too. But again, think of adenosine, think of rapid atrial pacing. Of course, there's all the other things that you can do that we sometimes forget about because we're in ICU, but other things that cause vagal stimulation, so putting ice to the face, suctioning them. Sometimes just a baby crying sometimes gets them out of it too. But just, you can use those, don't forget about those relatively easy things too. And then for SVT, if they're really keep coming back into it, and despite everything we're doing, or their adenosine and other things aren't working, then we'll start thinking about other medications. And I think the two that most commonly you'll probably see here are some form of beta blocker, so that's a propranolol or esmolol. And that just, again, you're just trying to slow their heart rate down so they don't get, so they don't go back into SVT. Again, neither of those are going to probably get them out of SVT, but if you get them out, then they won't hopefully go back in because you've started that medication. Amiodarone is going to be a little more effective too. That's going to just actually probably get them out. That can get them out of SVT, and then hopefully keep them out of it too. So those are some other treatments for it. But let me see if there was something else I wanted to. I think those are the big things that I wanted to hit on. Just like if you kind of think, I think it's important to kind of think about again, like the two, is that they are sort of different. The pathways of the arrhythmias are different. Where they start, and what they're called, and that's why they respond differently, and that's why you can't just, again, why adenosine doesn't work in jet, and it does work in SVT. I forgot to mention one big one. So cardioversion, that's another one that we can use too. So cardioversion again is giving a little kind of pulse of electricity, and when you do synchronized cardioversion, which is what we do for most tachycardias, we're not defibrillating a patient that's pulseless or in BF or BTAC. We're giving synchronized cardioversion, so a little pulse electricity. The machine is sort of sensing every heartbeat, so it's giving it right before the QRS. And what that does is, again, it sort of tries to restore the normal electrical activity of the atrium. So again, cardioversion is very effective in SVT, in atrial flutter, in atrial fibrillation, just the same way rapid atrial pacing is. So again, that's a treatment for it. Cardioversion will not ever help jet because, again, there's still just that automatic focus coming from that place we've talked about. So that's why cardioversion is never, you could do it all you want with as much energy you want, it would never work. So I think those are the big differences, and we talked about the different surgeries, what to kind of think about, and how we treat them. Any questions at all? Is that helpful? Sure.
Can we open up to any other questions? Anybody
Or
else
anything
have
else,
any
yeah.
other questions for Nate?
Any other like random
He still has 5 minutes.
Jeez,
Maybe he can just tell us a joke. What do you think?
I don't know.
Cookies, be nice.
Yeah.
All right.
All right, well, thanks for listening.
Thanks,
Thank
Nate.
you.
Thank you, Nate.